So good morning, let's get started. I want to welcome you to the State of Global Air 2019 release webinar on behalf of the Health Effects Institute and our collaborators at IHME, at the University of British Columbia, and the University of Texas. Thank you for joining us. I'm Katherine Walker, a principal scientist at HEI, responsible for managing this project, and I'm a co-author on the report. And before we get started into the details of the webinar, I wanted to give you a little bit of background on the origins and goals for this project. The State of Global Air really has resulted from a long-standing collaboration between the Health Effects Institute, we're a nonprofit research institute that for almost 40 years has been studying air pollution and its effects on health, and the Global Burden of Disease Project at the Institute for Health Metrics and Evaluation at the University of Washington, which is the most systematic and comprehensive effort to characterize the relative importance of major risks for population health around the world. One important result of this collaboration for us has been that air pollution has emerged as a major risk factor for disease and early mortality. You can see here from this ranking of different risks from the Global Burden of Disease Project that air pollution ranks as the 5th most important risk factor for early mortality. So what's our goal for the State of Global Air? It really is to make all of this data accessible to everyone. In particular, to make available data that aren't necessarily available on the Global Burden of Disease site itself. So in particular, we have provided on our site the data in every country included in the GBD estimates of exposure to fine particulate matter, to ozone, and to household air pollution, along with a selection of the health impacts that are included in the GBD: mortality, disability-adjusted life years, which is really a measure of the years of healthy life lost, and the related age-adjusted rates for each of those metrics. And finally, this year, life expectancy at birth. Some of the main findings you may recognize from the press coverage that we've had around the year, around the world. As in previous years, we continue to track important statistics like the percentage of the world's population living in areas above WHO's guideline for PM 2.5, the rates of usage of solid fuel burning in households and its implications for health. Still a very large number around the world, as well as the total burden from premature deaths globally, and where those deaths come from. In particular, over 80% come from non-communicable diseases. And finally, the finding that air pollution has reduced life expectancy worldwide by 1 year and 8 months on average. So our agenda for today is, where we can't possibly cover everything, is to really give you in the next 25 minutes an orientation to the data through an exploration that Dr. Pallavi Pant from HEI will lead you through for a particular country. We'll get a primer on where the exposure and health data come from within the GBD from Dr. Michael Brauer from UBC and IHME. And Professor Josh Apte will dig a little deeper into how life expectancy is calculated. But then we'd like to use the remaining time to answer your questions. So we're not going to entertain questions during the webinar, but please, throughout the presentation, as important questions come to you, send your questions via the chat, where our team will sort them so we can answer as many of the key questions that you have as possible. And as always, it's always possible to reach us after the webinar through the website, and we'll be happy to answer your questions. So with that, I'm going to turn it over to Dr. Pant. to give you an exploration of the data in Bangladesh.
Hello, everyone, and welcome to the webinar. We're glad you can all join us. As Katie mentioned, it would be really hard to go over all of the data that the site is making available for open access. But what I would like to do right now is focus on one country. And I've picked Bangladesh partly because it's one of the countries from the South Asian region that experiences one of the highest levels of air pollution around the world. It has a significant health burden, and it will allow us to delve into some of the details of the data that you have available at your disposal. So if we think about Bangladesh, it's a small country in the South Asian subcontinent, but average PM 2.5 exposures in 2017 were almost 61 micrograms per meter cube. And just to put that in reference, the WHO air quality guideline for healthy air is 10 micrograms per meter cube annually. And at the same time, when we think about PM 2.5 outdoors, we start thinking about all of the sources of air pollution. And in many countries across Asia and Africa, use of solid fuels, things like wood, charcoal, animal dung, etc., is still very common. And in Bangladesh, almost 80% of the population is still using solid fuels. So a significant proportion of the population in this country is getting exposed to household air pollution. At the same time, if we combine these different exposures that are happening outside and inside our homes, more than 100,000 people are dying due to exposure to air pollution. And we will learn a little bit more about the methods on how we get to this number later with Dr. Brauer. And in addition to the deaths that occur due to exposure to air pollution, we also experience loss in life expectancy. So people are dying earlier as a result of these exposures. And in case of Bangladesh, this is almost as high as 2 years, 1.87 years of life lost. And on the right panel here, you see the map. I've highlighted Bangladesh for those of you who are not very familiar with the where the country is. And I would now like to go to the State of Global Air website and walk you through some of the features on our interactive app. So this is the State of Global Air website for 2019. You can access it at any time. All of the information that is available on this website is open for you to use for non-commercial purposes. And I would welcome you to explore the website in your free time. Today, I will focus on exploring the interactive data section or explore the data page, as you can see on the top here. So to begin with, if you are looking at this page, we've got a few different options right at the top. You can look at detailed methodologies if you're interested in understanding how pollution exposures and health burdens are estimated. If you would like to use this as an interactive tool for teaching or training purposes, you can use the how-to guide. We've recently heard that a school group is using this for STEM education, which is very exciting. Now, focusing on the data app itself, we have two different options here. As Katie mentioned, the data provided on this website includes both data on air pollution exposures, but also health impacts. So mirroring that, we have two different tabs that talk about air quality and health impact. They're both very similar, so I'm going to walk through the air quality tab in detail and then highlight some of the features from the health impact tab as well. So on the left panel here, you can see that there's a range of options available. You can select what pollutant you want to look at. You can look at ambient PM 2.5, ozone, and household air pollution from solid fuels. You can select what country you are interested in looking at. You can add other countries. You can add different regions of the world if you're interested. And finally, you can also compare this data with the global averages. So let's stick to our example of Bangladesh and see how we can access all of these different data points that I talked about. So the first one, if we look at Bangladesh and we look at PM 2.5, you can see here that we have the annual PM 2.5 exposure numbers going all the way from 1990 to 2017. I said that in 2017, the exposure levels were 61. So here's where I got that number from. Now, let's say I'm interested in looking only at these concentrations starting in 2000 rather than 1990. What I can do over here is just select this area, and then I can look at this particular section of the time period. I might also want to see how my country compares with the global averages. So I can just add that in. And again, you can select the years as you would like. I can also add in other countries that might be of interest. So I'm from India, so I'm always interested in what's happening in India in terms of air pollution. So if I add India to the mix now, we see that the concentrations are relatively higher. We can also add other countries in the region. I'm going to add Nepal and Pakistan just for reference. So now we have these trends for all of the different countries. But I might also want to look at the regions. And on this app, we provide several options for classifying different regions, including the GBD classification, as well as the World Bank and World Health Organization classifications. And at any time, if you were interested in looking at all of the regions, you can simply select all and go for the entire
regions.
You can select all of the regions as well. So now this graph starts to be very crowded. So let's go back to our original example of Bangladesh and look at some other pollutants now. And I will highlight household air pollution, since I said almost 80% of the country's population is getting exposed to solid fuels. So this graphic presents this number as 0.79 because we are talking about the proportion of the total population that is using solid fuels. So we can see that globally, about 47% of the population is getting exposed to solid fuels. In Bangladesh, this goes up to almost 79%. So this is where you can look at the data in terms of a plot. Now, if you were interested in downloading this, you can download both images as well as CSV files as a direct data set from here. But we also have the option to look at the situation globally in terms of what's happening. So here we're looking at the proportion of population that is using solid fuels around the world. And as you can see, parts of Africa, parts of Asia are what we see really, come out. If you were interested in other countries, you can simply scroll through the map and look at those countries. I am interested in Bangladesh again, so I'm just going to zoom in to the region and look at the country of interest. So now I can see Bangladesh right here, 79% of the population is getting exposed to solid fuels. And similar to the plots, you can also download these images. You can download either the entire global map or a specific subsection of the map, depending on how you're planning on using this. And as is the case for the trend plots, you can also look at different pollutants. So you could look at ambient PM 2.5, and you could look at ozone and household air pollution. And then finally, what might be of most interest to some of you attending the webinar today is the data file. So here, we're looking at an example from Bangladesh. As you can see, I've selected ozone at the moment, so you're able to see ozone concentrations for all the different years that the data is available for. You can see what units these data are reported in, and exposure mean is what the average concentration is. So let's switch back to PM 2.5. And I said 61 micrograms, so we can go back and look at average concentrations. We also provide the uncertainty limits, so the exposure lower and upper are referring to the exposure uncertainties. What is the variability in the data that is being reported here? And again, you can download this data file and use it in any way you want. You can create your own visualizations, etc. So this is essentially what is covered in the air quality section. Just to summarize, you can download data on specific pollutants. You can look at countries and regions. You can compare across regions, and you can always compare with global averages depending on what part of the world you're in. If we move on to the health impact section, the interface is really similar. Again, you can select a variety of options. A couple of things that I would like to highlight here are that in the pollutant section, you will notice an air pollution indicator, which is combining the different air pollution metrics that we've used in this analysis and presenting a total number. So if we look at this, nearly 5 million deaths, as Katie pointed out earlier during the presentation. And then if we look just at Bangladesh, we have that number that we talked about earlier, more than 120,000 deaths in Bangladesh alone. But you could also look simply at what's the health impact as a result of household air pollution or ozone or PM 2.5. The other thing I just want to point out really quickly is that what we're looking at the moment is the total number of deaths that are attributable to air pollution. But you could also look at the rate of death. So how many people per 100,000 are dying as a result of exposure to air pollution. And in addition to the data on deaths, you can also look at the data for DALYs, or the healthy life years lost, for a particular country or a region or a variety of countries and regions. And similar to the air quality tab, you can look at the maps, scroll through, download, and look at the tables, and again, scroll through and download through these. So if you have any questions on any of this, feel free to submit them on the chat right now or contact us later on email. We welcome any suggestions as well on how you're using this data and how we can make it more accessible and engaging for everyone to use. With that, I would just point out to you the final piece, which is the life expectancy data, which Dr. Apte is going to talk about in a minute. So one new page that we've added to the website this year is the Engage page, where we want people to use some of this data. And as you can see, there's a variety of options for you to go through. A couple of quick things to point out: you can download all of the figures and data sets from the report if you're interested in using them. You can look at some of the profiles for specific countries. You can also download the total data set for exposures in health. And this is where you'll find the life expectancy data. It's not integrated with the app, but all of the data is available here for download. So you can simply click on this and you will be able to access the whole data set for all of the countries that were included in the analysis. So with that, I would like to bring you back to Katie, who's going to continue with the rest of the presentation.
Slide. So next, we're going to hear from Dr. Michael Brauer, who's a professor at the University of British Columbia and also currently leads the Air Pollution Risk Factor Group at the Institute for Health Metrics and Evaluation. So Mike?
Okay, thank you, everyone. So move to the next slide, please. And I'd like to go over some of the input data, and before doing that, just lay out the framework for the state of global air data, which is part of the global burden of disease, and to let everyone know that this is part of an annual cycle in which a large number of risk factors are estimated in terms of their contribution to diseases and injuries. So the air pollution risk factors that we're talking about today, particulate matter, household air pollution, and ozone, are amongst more than 80 different risk factors that are estimated. The global burden of disease estimates are calculated annually. And what that means is that each year new data are included and methods are updated. So it's not appropriate to really be comparing one year's set of estimates to another, but within each annual release, the time trends are recalculated each cycle. So meaning that each time a State of Global Air report is released, the time trends of air pollution exposure and its burden of disease are calculated from 1990 onwards to the year of the release. So in this year, that includes up to 2017. And again, each year, there's decisions made on including, for example, new risk factors. So in future years, there's the potential to include other measures of air pollution, as well as other diseases that may be impacted by air pollution. So next slide, please. So this slide lays out the framework for the estimation of the burden of disease. And we have three major components. So one is the estimation of exposure. One is the linking of that exposure to health response. And those are integrated with disease-specific burden estimates that are the foundation of the global burden of disease. And together that gives us how much of any particular disease we can attribute to air pollution. So to zoom in for a minute on the exposure estimation, next slide, please. We use a number of different sources of input data. For example, for particulate matter, the estimation of exposure is conducted on an approximately 11 by 11 kilometer gridded surface for the entire globe. And again, going back from 1990 to the present, this is combining satellite-based estimates that are combined with a chemical transport model to provide information on satellite estimates of the surface concentration of particulate matter. And then those estimates are calibrated to the available global data on particulate matter from ground monitors. So nearly 10,000 different monitors around the world are used in that calibration. And together those give us a continuous global surface of annual average concentrations of particulate matter. For ozone, we use a fusion of multiple chemical transport models combined as well with nearly 10,000 measurement sites of ozone around the world. And that is a measure of a seasonal average of 8-hour daily maximum ozone concentrations. And then for household air pollution, it's a combination of surveys on the proportion of households using solid fuels, such as wood, coal, dung, agricultural residue for cooking, and then database on the concentrations of particulate matter as an indicator of air pollution in households in which solid fuel is used for cooking, as well as personal exposures to particulate matter for members of households using solid fuel as a cooking fuel. So next slide, please. So those global exposures are then compared in each case to a minimum risk exposure level. And the difference between that indicates the exposure that is attributable to that level of air pollution. That minimum risk exposure level in the case of household air pollution would be actually no cooking with household solid fuels. But for the example of ambient air pollution, it would be a low level of air pollution because there are natural sources of air pollution. So the difference between those are then put into an exposure response relationship that is disease specific, and where information exists also would be age specific or sex specific. And that gives us the level of risk for any given level of exposure. And for air pollution, we're looking now at 5 different diseases: so stroke, lung cancer, ischemic heart disease, diabetes, and chronic lung disease, COPD, chronic obstructive pulmonary disease. Together now, combining the information on exposure with this exposure response relationships gives us the fraction, the population attributable fraction due to air pollution. And that is then combined with the core data from the global burden of disease, which tells us about the numbers of people being affected by all the different diseases. and then allows us to calculate how much of each disease's burden is attributable to particulate matter, ozone, or household air pollution, or the sum of all air pollution. Next slide, please. And as I mentioned, because of this annual cycle and annual updating, each year we're trying to improve the estimates, both by adding in new information, new data sources on exposure, new data sources on the level of disease around the world, but we're also including new information on our understanding of the relationship between air pollution and its health impacts. So we update the methods and improve the methods based on this new understanding. So just to illustrate a few of the changes that we made in this last cycle in terms of methodology and data, this year we implemented an approach that reduced the potential for double counting of those parts of the world where there's exposure both to outdoor air pollution and household air pollution. For ambient particulate matter, we've added additional spatial and temporal variation in that calibration of the satellite data. And for ozone, we really completely updated the exposure methodology to include multiple chemical transport model estimates and a newly available global database of ground measurements, as well as updating the actual exposure metric to better reflect the understanding of the epidemiology in terms of the effects of long-term exposure to ozone on chronic lung disease. In terms of data, every year we're looking for new sources of data. So in this cycle, we've added almost 4,000 new additional ground monitor measurements of particulate matter. And as I mentioned, added the ozone ground monitoring database that is newly become available. And for household air pollution, many of these surveys are done annually or semi-annually and have been updated in multiple countries around the world, as well as updating the concentration measurement database. And for the exposure response function, we're looking to, and have included new epidemiologic studies that improve our understanding of the relationship for the specific diseases. And as one example of that, we have added an additional health outcome that is now linked to air pollution, and that is type 2 diabetes.
Okay, thank you very much, Mike. And let's move on to Professor Josh Apte, who is an assistant professor at the University of Texas in Austin. And his work on loss of life expectancy was published in Environmental Science and Technology Letters, where it won the Best Paper in 2018 award. So Josh will be telling us about how these estimates are arrived at.
Thanks, Katie. So we care not just about the overall impact of air pollution on mortality. Ultimately, every human dies, so we also care about by how much the human lifespan is reduced by air pollution. And I'm going to explain to you briefly how we made an estimate of this impact of air pollution on life expectancy for every country in the world using the underlying demographic and statistical methods that form what is called a survival curve or life table that feed into this metric of life expectancy. So many of you have probably thought about this metric of life expectancy, but perhaps not looked in detail at how it's calculated. So I want to give you a brief context for how it works. Very simply, what life expectancy is designed to tell you about is the expected lifespan of a population, assuming that mortality rates hold constant into the future. So specifically, we're talking about the life expectancy at birth of a cohort that would be born today. And so what we're looking at is how long a cohort of infants born today would be expected to live on average in a given population, assuming that the probability of surviving from one age to the next is determined by today's mortality rates. That may seem like an oddly specific way of defining life expectancy. That's actually the formal definition of life expectancy in the demographic field. So we do this by taking from the Global Burden of Disease Project data on mortality rates at every age for every country, almost every country in the world. And what this allows us to do is to estimate the probability of surviving from one age to the next. That set of probabilities forms something called a life table, and it allows you to construct something called a survival curve, which I'm showing you here for two countries, China and Nigeria. So the idea is that at birth, right after birth, 100% of the population that's born is alive, and on average, a human's not going to, or at the extreme, a human's not going to live much beyond 100. And so as one ages and ages and ages, some portion of the population is no longer surviving. And so we see this here for both China and Nigeria. Next slide, please. So for example, after about 5 years in Nigeria, a little bit more than 10% of the population has already died. So that speaks to the relatively high rates of infant mortality in Nigeria. Whereas to get an equivalent loss of survival in China, you have to look all the way out to about 60 years. So only by the time 60 years have elapsed would a Chinese population born today have lost 10% of its birth cohort. But of course, as you reach older ages, then survival starts to plummet precipitously because most humans have an expected lifespan in the 70s or the 80s. And so coming to precisely this definition of life expectancy, you can think about life expectancy graphically on this chart as the area under an individual curve for a country. And so because the Chinese population doesn't experience a high rate of infant mortality and stays reasonably alive until the 50s and 60s when some people start dying, the average life expectancy in China is considerably greater than that in Nigeria. And this speaks to a really important feature of how we care about how air pollution affects different populations differently, which is that the effect of any one disease on life expectancy depends on everything else demographically that's happening in a country. And so you have to account for that interaction if you want to understand the relationship between air pollution and life expectancy. Next slide, please. So the way we do this is that we simulate a hypothetical scenario where we take away air pollution as a risk factor for death. And what that then means is that one's probability of living from one age to the next goes up a little bit at every step in survival because air pollution is no longer killing people in this hypothetical scenario. And so I'm plotting new survival curves here as dashed lines for both Nigeria and for China. Because people survive a little bit longer when you take away air pollution, if you analyze the life expectancy for these new survival curves where you eliminate all air pollution exposures, life expectancy increases each for both Nigeria, China, and for most countries around the world when you take away the different types of air pollution as a risk factor. So here I'm showing you what happens if we would remove PM2.5 outdoors, so ambient PM2.5 as a risk factor for mortality. And we can see that that little increase in the probability of survival translates into an increase of life expectancy of about 1.25 years in both China and Nigeria, despite very different levels of pollution and different underlying survival rates in these two countries. One virtue of this approach is it allows us to simulate the effect in different populations of different changes in air pollution. So we can look at this hypothetical case where we remove air pollution altogether, and that's what allows us to estimate the aggregate impact of air pollution on life expectancy for a given population. Or we could look at partial improvements. So for instance, what would happen if we tried to achieve the World Health Organization guidelines of 10 micrograms per cubic meter around the world. Next slide, please. So here I'm showing you the total impact of ambient PM2.5 outdoors on life expectancy for every different country on the planet. And we can see that there are some countries, especially the very polluted ones in South Asia and in Africa, that experience very large decrements in life expectancy. So 1.9 years, people in Egypt survive 1.9 years longer than they would otherwise without PM2.5. In India, it's 1.5 years. It's a little bit more than that in Bangladesh. And it's a little more than 1.25 years in China. Even in the US, where PM2.5 levels are very low, there is still a substantial reduction in life expectancy, a little bit more than 1/4 of a year, almost 1/3 of a year. And what we're going to see on the next slide, please, is that these impacts on life expectancy are actually quite large compared to many of the other things that we know impact human survival and well-being quite substantially. So I'm showing here in colors 3 different metrics of the impact of air pollution on life expectancy. In the blue bar, we see the total impact of all types of air pollution. So this is ambient and household air pollution from PM2.5 and ozone. That's a year and 8 months for the global average. Of course, this differs country by country. Ambient 2.5 has an effect for the global population of about a year, and we saw some of the range of that in the previous slide. And then household air pollution has an average global effect of about 9 months, shortening life expectancy. And of course, the places around the world that have these impacts are different in different places, and that is one of the many reasons why the global aggregate total is not quite the sum of its parts. Let's put this in comparison, though. So if we look at some other major global health priorities, so for instance, if we completely tackled at the maximum achievable level our water and sanitation problems, we'd have less of an impact on human survival than if we completely tackled the air pollution problem by about a factor of 2. Even some of the major cancers like lung cancer and breast cancer, completely curing them would do less to increase life expectancy than if we fully tackled the remaining air pollution problems around the world. And I found that particular finding quite surprising when we first made it. And I think it speaks to the profound impact of air pollution on public health around the world, and also the opportunity that we have to give people longer, healthier lives if we can improve air quality around the world.
Okay, thank you very much, Josh. So now to your questions. We already have a number of questions here from you, and I'll first read the questions for you and then determine who can go ahead and answer them. Just a quick question. We did have a question about sort of that precedes really all of this work that you see here, which is a question about, do we have available emissions by sector? And our work here does not include the emissions data. There are a number of studies around the world that are looking at sectoral emissions and their contribution to air pollution in different regions and different countries. I mean, for example, we have 2 studies which you can find on our website about where we conducted analyses in China and India. So I direct you to those studies as an example. So next we have a number of questions that I'm going to send to Mike Brauer about the measurement data. They include what percentage of monitors are in low-income countries, and a related question is really for satellite measurements in low-income countries. What's their calibration and accuracy there?
So thank you, Katie. I'll answer that just very generally and briefly, and would refer you to some of the references that are listed on the State of Global Air website that provide much more detail on that methodology. Depending on the pollutant, so for example, for ozone, there's a rather small number. I don't have exact counts in low-income countries. That is increasing, and for particulate matter, we are seeing actually a growing number of monitors in low and middle income countries, in particular in Asia. Africa is still a continent where the ground monitoring is sparse. But again, every year we're updating with additional measurements, and actually most of the growth in new measurement sites is occurring actually in low and middle income countries. And so when we actually are now starting to look at the next cycle for the State of Global Air, we're seeing, for example, from the US State Department increasing monitoring in some of the major cities in Africa. Because of that situation, the level of error is certainly greater in locations where there is less ground monitoring data. But globally, we're seeing errors less than 10 micrograms per cubic meter in terms of the annual average of particulate matter. And this level of error that we're estimating from this exposure model has been decreasing each cycle as we take new input data on ground monitors and also improve the calibration function. So certainly there is still uncertainty and there is still error, and it is highest in low-income countries, and I would highlight Africa as a part of the world where that sparseness of ground monitoring is most acute.
Okay, thank you. So another sort of important sort of background question that I think has been raised is really, how do we determine air pollution is a factor as a cause of death? And I think the question really is about, how do you do this when you don't have death certificates and doctor's notes? And you know, I would say that the answer to the first question, how do we answer these questions about relationships between air pollution and health, is largely through a combination of different types of studies, but importantly, starting with epidemiology studies, which are really studies of the relationships in populations between particular exposures and health outcomes. Now, of course, a lot of the studies have been done in countries where doctor's notes or death certificate data are available, and so those are a very important piece of groundwork and data in order to conduct these studies. But these epidemiologic studies are then combined with evidence from animal studies, from evidence from in vitro or sort of experimental toxicology studies, to create a more complete picture of the role, both mechanistically and in terms of total impact, that air pollution has on health. So let's see. Another question that relates really to the health effects is, we've had a number of people say, why diabetes? Where does that come from? What does the science say? And I'll just start by saying we began looking at diabetes a couple of years ago at HEI and did a preliminary review, which was then sent on to the Institute for Health Metrics and Evaluation. And Mike, I wonder if you could pick it up from there and talk about the process that IHME goes through to evaluate a new health outcome and include it.
Yeah, so to take diabetes as an example, so basically the inclusion of diabetes as a new disease that's linked to air pollution is based on the epidemiologic evidence. And this is supported by some mechanistic information. And just to give very briefly, this is linked to the general inflammatory response that we see in the response to air pollution, so inflammation in the lungs that then spills over into the general circulation. And as a part of this inflammatory response, tissues and cells that are involved in diabetes and insulin resistance and other metabolic functions may also be disrupted. We also see air pollution affecting lung irritant receptors that leads to an autonomic nervous system response, which can also affect insulin resistance. But focusing on the epidemiologic evidence, what the Global Burden of Disease does is looks at the evidence scoring system developed by the World Cancer Research Fund, and includes evidence that through those criteria are deemed to be either convincing or probable. This means essentially two types of epidemiologic evidence have to be available, either prospective cohort studies or case control studies. So any other type of study actually is not included. And that evidence base has to be based on consistency between studies that shows associations between the exposure and disease with little or no evidence to the contrary. That evidence also has to be based on a substantial number of studies, and where available, although this is usually not the case, if there's also any randomized control trials, those would also be included. And then finally, the association should be biologically plausible. So the evidence is viewed, and each cycle we actually view evidence for additional risk factors, and in many cases the evidence is deemed to be insufficient, whereas there may be individuals in the research community are continuing to do research and suggesting that there may be a link between that exposure and that disease. So again, this is reviewed periodically, and we're each cycle we're continually scanning the literature to see what new evidence has become available, and then putting it through this evidence grading system. And I'll just add that, for example, in the future, this evidence scoring is likely to become much more quantitative in a way that we'll actually be looking at data from individual studies. How do they agree with other studies? What is the heterogeneity of responses between studies as a way to actually formally and quantitatively evaluate that consistency?
So Mike, we just had a related question is, can the methods that IHME uses and be shared for how they evaluate the connection between air pollution and diabetes? I believe there's a paper coming out on that soon, right?
That's right. So we're also trying each year or so to publish papers that provide more information on the data sources. In the interim, one can always go to the core risk factor papers, which are linked under the data sources and the references on the State of Global Air website. And in the appendices of those papers, so as you can imagine, those papers cover nearly 3,000 different diseases and 84 different risk factors. So in the core text of the paper, there's not room to provide a lot of methodologic detail. But there's appendices on the methods that provide much more detail on the specific studies that are included and the basis of their inclusion, and provide, for example, information also on the exposure and how it's estimated. So those appendices provide a wealth of information, and you can actually search within the appendix for a section on each risk factor, whether that be PM 2.5, ozone, or household air pollution.
Okay, let's take a couple of questions on the life expectancy for Dr. Apte. I had a question about sort of the range of life expectancy worldwide, and related questions are, where do most of the air pollution deaths happen? As you're thinking about life expectancy, and then finally, again, to put life expectancy into perspective, how is its impact comparable between other risks, for example, breast cancer? And we might go back to another slide if we can to answer that one. But Josh, do you want to talk a little bit more about life expectancy and how it varies around the world?
Yeah, certainly. So first, let's talk about how air pollution's impacted life expectancy varies country by country. The map figure, I think, provides a nice illustration of this. In the relatively cleaner countries, sort of Brazil or Australia would be good examples of this. You know, there could be less than a month of impact on the survival in those populations because the risks from PM 2.5 are minimal in those countries. And then in other countries where the PM levels are extreme, and also there can be an interaction with the underlying causes of death in middle and late middle age and in the elderly years. From cardiovascular disease and cancer. So Egypt is a good example here. You can find strikingly high impacts on survival. If you go back to the previous slide, Katie, what you'll see is the impact of air pollution on life expectancy in different ages. So if you look at the distance essentially between the dashed line and the solid line for any one country, you can see that in these two countries, for example, it really starts to separate starting in the late 40s, early 50s, and becomes quite significant by the 60s. And what this is showing is that the people that are dying from air pollution-related causes are not just very elderly people in their 70s and 80s, but also starting in late middle age, there can be a really substantial impact of air pollution on life expectancy. And this is one of the reasons why, although most people in most countries don't die directly from air pollution, the aggregate impact of PM 2.5 on life expectancy can be quite large across the entire population. because those who are dying are dying. They could be losing 10 or 20 years off of their lives from the deaths from PM 2.5. It should also be worth mentioning that if you're interested in reading more about this, there is an entire journal article that was published in ES&T that Katie linked to, that you'll be able to learn a little bit more how air pollution affects survival at different ages. One of the things that we calculated is the hypothetical gain in the probability of surviving from age 60 to 80 in countries around the world. And it's quite surprising that in countries, for instance, like India, that one's chance of surviving from age 60 to 80 can go up by 15 or 20% if air pollution were dramatically reduced as a risk factor for mortality. And so the chance of living through sort of one's elderly years can go way up, even though there's also a substantial impact in the 60s and 50s.
And I would just simply add that to remember that these are chronic diseases. These are resulting from exposure over a lifetime. So although we often see their impact, in these later years, their effect on the body begins to occur from much sooner and from birth. So a related question, somebody had asked sort of at what percentage of kids under 5 die, for example, in Nigeria, where there's a lot of household air pollution. You can actually, we don't have the age-specific data on our site, but you can find this information on the Global Burden of Disease site by risk factor, by age. And I won't go into that now, but if that person is interested in understanding how to do that, please get into contact with us separately. So we've had some number of questions about the big drop in death projections since last year and what explains this. And Mike started to get into this a bit and perhaps could touch back on that. Some related questions are really, how do you double count ambient and household air pollution? Can you give an example of how that works and how you've sort of managed to separate them?
Yeah, so I'll give that a bit of a try. And again, this I would refer you to the appendix for the core global burden of disease risk factor paper that provides some more detailed information. But for example, in the previous release of the global burden of disease, so last year's State of Global Air report, what we had for somebody who is exposed to household air pollution, we were actually comparing the burden attributable to the combined exposure of household air pollution and ambient air pollution. So for example, if somebody lived in a home where they had been cooking with solid fuels, but then removed that solid fuel, they would still be exposed to or could be exposed to appreciable level of air pollution outdoors. And we had actually been also assuming that outdoor air pollution exposure went to 0, which is incorrect. So this year, for example, when we mapped the levels of exposure for those using solid fuels, we actually subtracted the level of exposure in each location at each point in time from every location that was due to outdoor air pollution. So if somebody then removed so the difference in risk for somebody who changed from using a solid fuel to not using a solid fuel was just that due to removing the solid fuel, where they still would have that risk from being exposed to outdoor air pollution. And that both affects the disease burden from household air pollution. So it's decreased because we've removed that double exposure. It also affected the risk from outdoor air pollution in those places in the world where there was appreciable exposure to household air pollution. And that's because the exposure response function that we use is the same function for both household air pollution and outdoor air pollution, but it's not a linear function. So meaning that as you add on, for example, household air pollution exposure to outdoor air pollution exposure, your risk doesn't go up in a linear fashion. It actually flattens out. And we actually don't know which one of those sources to remove first. So we could actually, and depending on which source you remove first, you would actually get a different amount of disease burden because that function is non-linear. So in order to deal with that problem, we just apportion the total exposure that an individual in one of those locations would receive from the contribution of household air pollution or outdoor air pollution to their total exposure. So in a place where there's high exposure to household air pollution, that will also reduce the disease burden that we calculate from outdoor air pollution. And it just so happens that some of those countries in the world that have appreciable amounts of household air pollution are also the countries where there's a lot of the disease burden from outdoor air pollution, in particular China and India. So in dealing with this double counting, we actually reduced the overall disease burden from household and ambient air pollution, and in effect actually reduced the global estimation because of the impact of places like China and India.
Thanks, Mike. So we have a couple of questions that really go to the time scale and the spatial scale at which we provide these estimates. And I'll take a stab at these and have Mike and Josh jump in as well. But one question is about, do we have data on monthly and weekly or even daily concentrations? Because we all know that in different parts of the world that sometimes seasonal changes are really important. And the quick answer to this is no, we don't capture these on the site or as part of the global burden of disease work at this point. And that's partly because we're really focused on long-term exposures and their impact on chronic disease. But short-term exposures are clearly important ones. We direct you to some other sources for short-term levels of air pollution on sites like OpenAQ and others that post air pollution data from around the world on a daily basis. And we do have a link to that on our site. Another question really is about whether or not we have city-specific data available. And there certainly are city-specific data available in some parts, in various publications. They're not available on this site. Again, we're focusing largely on national averages, but work is ongoing now to try and develop those estimates, and will be coming out soon. I don't know, Mike, if you want to add to any of that.
So just the exposure data for cities could be made available with the caveat that much of it, and many cities of the world wouldn't have any of their own ground monitoring. So it would be done with these sort of global estimation approaches. The big gap in terms of providing information at the city level is actually having the burden of disease information available at the city level. So as you can appreciate, the level of diseases may vary from location to location within a country. This sort of subnational estimation of disease burden is increasingly an emphasis of the global burden of disease. So now actually all countries with populations greater than 200 million individuals, those have what we would call subnational estimates. So in those cases, the national information that's provided here are calculated subnationally, but because of data sharing agreements with those individual countries, in some cases those data are publicly available, in some cases they're not publicly available. So just very generally, I think over time we increasingly will move towards more subnational and eventually even city level estimates of the attributable disease burden. But the big gap is actually not on the exposure side, but it's actually on the disease burden side.
Great, thanks. We have just a minute or so left, and there's an important question that's on the table here about the differences between the estimates for the global burden of disease and the new estimates that have been published by Lilleveld and his colleagues that suggest a doubling in the mortality figures. And this really goes to the underlying exposure response relationships that are used in the modeling for these two sets of estimates. And Mike, would you like to try and tackle this one as well?
Yeah, so as I mentioned, we're using the same function to estimate the exposure response for outdoor air pollution as well as household air pollution, and also even extending to secondhand smoking, because these are all exposures that are related to combustion and can be estimated by the concentration of particulate matter. This new function that has been developed only looks at data from outdoor air pollution studies, and it turns out that that shape, or that the slope of that relationship, is actually much steeper for outdoor air pollution than it is, for example, for household air pollution or for secondhand smoking. But the problem with extending that information is that we actually don't have studies that cover the entire range of global exposure. So we would be then extrapolating if we use that steeper risk function. But I would just add, more generally, this gives us some information that the estimates that are reported on the State of Global Air website may be conservative. It depends on basically what data sources you're including to estimate that exposure response function. And as we get more studies that span the full global range of exposures, both at the low end, so how low, what is the low level at which we do not see any impact of air pollution, as well as at the high end, so at the high levels of exposure, what is the shape of that relationship, we'll be refining that exposure response information. So that's why it's critical actually to be doing epidemiologic studies that we can incorporate at these higher levels of exposure.
Great, thanks very much, Mike and Josh, for joining us, and to all of you. If we weren't able to get to your question here today, please follow up with us, and you can also be looking for an email for us to answer some of them in a follow-up email. But we invite you to go back to the website and look for some of the answers that you may have. I mean, for example, we do have a fact sheet on short versus long-term exposures and impact on health to help begin to explain that kind of difference. But again, we want to thank you all for joining us, and we welcome your comments and suggestions for issues that we might delve into greater detail on, and subsequent updates to the site. So thanks very much again.